Clinical examination in hematology. Thrombocytopenia and purpura. Case. This woman presented to the emergency department with a nosebleed and 2-month history of menorrhagia. Her platelet count is 7 × 10⁹L, normal range 150–400. Please examine her abdomen. Causes of thrombocytopenia. Increased destruction, normal bone marrow. Non-immune. 1 DIC, sepsis and malignancy. 2 chronic liver disease and hypersplenism. 3 pregnancy, including hemolysis, elevated liver enzymes, low platelets. 4 thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. 5 inherited thrombocytopenia, Wiskott-Aldrich syndrome and Bernard-Soulier syndrome. Immune. 1 autoimmune diseases, SLE, rheumatoid disease, chronic lymphatic leukemia and lymphoma. 2 drugs, heparin, gold, penicillins, and digoxin. 3 infection, Epstein-Barr virus, hepatitis, HIV, and malaria. 4 post-transfusion purpura. Reduced production, abnormal bone marrow. 1 leukemia. 2 lymphoma. 3 myelodysplasia. 4 myelofibrosis. 5 myeloma. 6 metastatic malignancy. 7 aplastic anemia, primary or secondary, e.g. drugs, megaloblastic hemopoiesis, B12 and folate deficiency. 8 congenital bone marrow failure syndromes, rare, Fanconi anemia and congenital megakaryocytic hypoplasia. Introduction. Consider the causes of thrombocytopenia as you approach the patient and be alert to the possible signs. General features. Look for signs of chronic blood loss, pallor, conjunctiva, and tachycardia but normotension. Look for evidence of bleeding. Non-mucosal, look for bruising and purpura. Is the bruising extensive? Does bruising occur in areas not usually subject to trauma, e.g. the face, neck, and body? If there is extensive bleeding in the limbs, then it is very important in routine clinical practice to look for evidence of a compartment syndrome, but this is very unlikely in PACEs. Mucosal, look in the nose for blood and in the mouth for blood blisters, making sure that you have a good look at the tongue and soft palate. If there is bleeding in the mouth or pharynx, then it is vital to check if the upper airway is compromised. This would indicate stridor and wheeze, but again this would be a remote possibility in PACEs. Abdominal examination. The key feature to look for in this case is clearly splenomegaly, which could be a feature of systemic lupus erythematosus, SLE, leukemia, or liver disease in this context. Further discussion. What factors are important in a bleeding history? When was the bleeding and bruising first noticed? If it occurred during childhood, think of congenital causes. If during adult life, think of acquired causes. Where are the sites of blood loss? Is there a single site of blood loss or many? A single site suggests that there might be a structural cause that requires local treatment. Bleeding from multiple sites will often involve skin and mucosae, nose, mouth, gastrointestinal tract, and menstrual. How much does the patient bleed and how often? How are their energy levels and how has the bleeding affected their life? Is the bleeding causing symptomatic anemia? What is the most exercise the patient can take, and what stops them doing more? Quality of life issues may affect any decisions to treat. What is your differential diagnosis in a patient with a very low platelet count? Causes are broadly divided into those conditions associated with normal platelet production but reduced platelet survival and those presenting as a result of bone marrow disease. Generally, reduced platelet survival is associated with isolated thrombocytopenia, whilst reduced platelet production is frequently associated with other cytopenia. Based on your differential diagnosis, which investigations would you arrange and what conditions might they detect? FBC, look for pancytopenia suggesting bone marrow disease. Blood film, to confirm thrombocytopenia and look for evidence of hemic malignancy, e.g. circulating blasts in acute leukemia, lymphocytosis, and smear cells in chronic lymphocytic leukemia, and also to look for red cell fragmentation that is seen in thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. Clotting studies, prothrombin time, activated partial thromboplastin time, fibrinogen, and D-dimer to detect DIC. Renal and liver function tests, vitamin B1-2 and folate, and prostate-specific antigen, when appropriate to detect renal failure, thrombotic thrombocytopenic purpura and hemolytic uremic syndrome, chronic liver disease, hematinic deficiency, and prostate cancer. Blood cultures, viral studies, and Paul Banel test, to look for sepsis and infection. Autoantibodies, SLE and rheumatoid disease. Bone marrow aspirate, bone marrow infiltration or failure. CT scan of the abdomen, to confirm any organomegaly and look, in particular, for lymphadenopathy. This woman is diagnosed with IDP, what are the treatment options in the acute situation? First-line treatment of IDP is generally oral prednisolone 1 mg/kg daily, to which most people respond within a week with a rising platelet count. Intravenous immunoglobulin, 1 g/kg on 2 consecutive days, is also effective first or second-line therapy. Tranexamic acid 1 gram orally 4 times a day may improve clot stability and reduce bleeding. In an acute scenario, any bleeding needs to be controlled and the patient supported with fluids and red cell transfusion as appropriate. Platelet transfusions are rarely helpful as platelet survival is so short, but they may be considered in extremis. Jaundice and anemia. Case. This 21-year-old, male, university student has presented with a fever and yellow eyes. Please examine his abdomen. Introduction. In PACES it is almost certain that patients will have a chronic condition, but acute conditions are possible and, even if the case is not an acute one, the examiner may decide to move discussion away from chronic diseases that you are likely to have rehearsed. NB. Examiners often move discussion away from chronic conditions to acute presentations with similar physical signs, so be prepared for this. General features. Is the patient jaundiced? The history would suggest this. Look at their skin color and the sclerae. Are there any obvious rashes or petechiae? This may suggest an infective origin or associated low platelet count. Does the patient appear pale? In this case he does. Are there any abnormal masses visible? Cervical lymphadenopathy may be obvious from the end of the bed. If it is, then note whether this is symmetrical or not. Palpate the neck carefully and also feel for lymphadenopathy in the axillae. Are there any features of chronic liver disease? Abdominal examination. Examine the groins for lymphadenopathy. Look for the presence of hepatomegaly and splenomegaly, and pay particular attention to whether this is painful or not. Further discussion. What is the most likely cause of jaundice and pallor with tender hepatosplenomegaly and lymphadenopathy in a young patient? An Epstein-Barr virus, EBV, infection, infectious mononucleosis. In such cases splenomegaly occurs in over 50% of patients, although hepatomegaly is less common. Symmetrical lymphadenopathy occurs in up to 75% of patients. How would you confirm a diagnosis of infectious mononucleosis? You would expect an FBC to show lymphocytosis, with reactive lymphocytes on the blood film in a positive Paul Banel, Monspot, test. A definitive diagnosis can be made by demonstrating a high EBV immunoglobulin M titer in the blood, although this is seldom necessary in routine clinical practice. The FBC may also show thrombocytopenia. What is the likely cause of the anemia and how would you investigate this? Although anemia and jaundice may coexist for a number of reasons, the most likely cause in this scenario is hemolysis secondary to infection. Appropriate tests would include bilirubin, reticulocyte count, haptoglobins, lactase dehydrogenase, Coombs test, direct antiglobulin test, and a blood film to demonstrate spherocytes. Would you do any other tests? Liver function tests may be deranged in an acute viral illness, and it would be appropriate to check the clotting tests. It may also be appropriate to test for other infections, in particular cytomegalovirus, and a wider differential diagnosis of infectious conditions would have to be considered if there was a travel history or if the patient were immunocompromised. NB. Acute lymphoblastic leukemia may present in an identical manner to infectious mononucleosis. Splenomegaly. Case. This 35-year-old woman has had upper abdominal discomfort for 3 weeks. Please examine her abdomen. Introduction. The relatively nonspecific instruction in this case gives no clue as to what you will find, but does suggest that whatever is there may be tender. Therefore, take particular care to feel gently to start off with and do not palpate an obviously tender organ at great length. To do so would not be kind, necessary or sensible in any circumstance, and examiners in PACES are instructed to fail any candidate who causes a patient an inappropriate amount of pain. Causes of splenomegaly. Hematological. Hodgkin's disease and non-Hodgkin's lymphoma. Chronic leukemia, myeloid or lymphoid. Myeloproliferative diseases. Thalassemia major. Hemolytic anemia. Non-hematological. Portal hypertension. Storage disease, e.g. Gaucher's or Niemann-Pick. Systemic disease, e.g. sarcoidosis, amyloidosis, and systemic lupus erythematosus. Acute infections, e.g. infectious mononucleosis, bacterial endocarditis and typhoid. Chronic infections, e.g. tuberculosis, malaria, and schistosomiasis. General features. Look for clues regarding the sort of condition that the patient has. Hematological. This can be associated with pallor or polycythemia, petechiae, purpura, lymphadenopathy, or an indwelling chemotherapy line. Hepatological. Are there any stigmata of chronic liver disease? Look for hepatic failure or flap, clubbing, leukonychia, Dupuytren's contracture, palmar erythema, spider nevi, bruising, jaundice and, in men, gynecomastia and loss of secondary sexual characteristics. Renal, arteriovenous fistula, radial or brachial, or an indwelling dialysis line. Abdominal examination. Observation will show scars and swellings. Gentle then deeper palpation will elicit any tenderness and may reveal a viscous. Formal examination for liver, spleen, and kidneys should follow, taking care not to cause gross discomfort. NB. If the spleen is obviously palpable and tender, do not keep pressing on it. Further discussion. Try to assimilate the positive and negative signs related to the list of likely diagnoses, and commence with the most likely before moving on to the rarer causes. Making an inspired guess at a rarity looks foolish rather than clever. How would you investigate a case of non-tender 12 cm splenomegaly? To diagnose what is likely to be a hematological cause, perform an FBC and film, a bone marrow examination, a CXR, and a CT scan of the chest, abdomen and pelvis, looking for lymphadenopathy. To screen for possible effects and complications of a hematological disorder or other medical problems, check electrolytes, renal, liver and bone function tests, glucose, a clotting screen, and immunoglobulins and protein electrophoresis.